Greetings. Let us talk about large volume paracentesis to manage a patient with cirrhosis and ascites. I want to thank many who support this program, and please take a minute to read this. All right. So you have a patient with ascites, grade 3 ascites, and which is recurrent and also becoming refractory to your medical management of low sodium diet of 2 grams per day, and you put them on maximum doses of diuretics that is tolerable. When you use diuretics, is maximum tolerated dose or maximum dose is uh, spironolactone 400 milligrams, furosemide 160 milligrams per day. And the patient is not able to excrete the sodium, and you can't increase any further your diuretics. So in that case, you consider paracentesis to relieve the distension. And if you remove more than 5 liters of ascites in one setting, that is known as large volume paracentesis. So that is more than 5 liters in one setting. So when you remove large amounts of ascites, it is going to cause some circulatory dysfunction. And just to review, in cirrhosis of liver, there is resistance at the sinusoids, resulting in splanchnic congestion, uh, decreased effective circulating volume, increase in sympathetic renin-angiotensin-aldosterone system, along with vasopressin increase, and all these hormones act on the kidney, retain sodium, retain water. In end stages, can cause renal vasoconstriction also, and retention of sodium results in increase in uh, effective circulating volume. That in turn on the heart increases the cardiac output, further increasing in splanchnic flow, and again splanchnic congestion, and the vicious cycle continues. So when you take out ascites, especially large amounts of fluid, more than 5 liters, it is going to further worsen this vicious cycle by fluid shifts that happen after removal of the ascites and decrease in effective circulating volume, increase in hormones, renal vasoconstriction, and hepatorenal syndrome potentially. So this pathway of worsening with removal of large amounts of ascites can be mitigated by trying to preserve the circulating volume by giving intravenous albumin that has oncotic properties and tries to preserve the circulating volume and tries to interrupt this further worsening of the vicious cycle. So intravenous albumin will improve the circulating volume, resets the potential worsening of the hormones, and also renal vasoconstriction, and prevents hepatorenal syndrome. So keep this pathway in mind. This is very useful when you see a patient with cirrhosis. So when it comes to large volume paracentesis, by the time patients with cirrhosis develop severe ascites, grade 3 ascites, they will also have thrombocytopenia. They will also have coagulopathy. So should you worry about their platelet count? And should you worry about their prolonged INR? The answer is no. In a large series of patients undergoing large volume paracentesis, it was safely done even when the platelet counts was less than 50 and INR was more than 1.5. So something to keep in mind. Uh, and when it comes to the technique of ascitic tap, I want you to keep this thing in mind. Don't go straight in. The best site is the left lower quadrant, midway between the umbilicus and the anterior superior iliac spine. And uh, before you puncture, you can use the Z-track to prevent ascitic leak after you have removed the fluid. And whenever you tap ascites, once the diagnosis of cirrhosis was made, um, and ascites secondary to portal hypertension was made initially based on a high serum ascites gradient and a low uh, ascitic protein. Every time you do a tap, make sure you send the fluid for cell count. Important to rule out SBP whenever you get a chance because sometimes it could be asymptomatic. So when it comes to paracentesis, you put a large bore needle and try to remove the fluid. And if you remove more than 5 liters, it is known as large volume paracentesis. And this is likely to cause problems with post-paracentesis circulatory dysfunction and precipitate hepatorenal syndrome. That could be prevented by giving intravenous albumin. On the other hand, if you have somebody who has large amounts of ascites, but their systolic blood pressure is on the lower side, and the serum sodium is also low, and their BUN and creatinine are slowly going up, uh, this again indicates that their effective circulating volume is pretty low. In that case, even if you tap just a couple of liters to relieve the distension of the abdomen, you should consider intravenous albumin infusion. So something to keep in mind. It's not just for large volume paracentesis. The protective effects of albumin should be considered in patients where you remove smaller amounts, especially when you know that their circulatory system is already under maximum stress. So, how much of albumin should you give? A lot of work has been done from Spain, Barcelona, Spain, and they've shown that 6 to 8 grams of albumin for every liter of ascites that you remove after 5 liters. If you remove more than 5 liters of ascites, after 5 liters, you should at least give 40 grams of albumin. And on the other hand, say for example, you want to remove larger amounts of ascites to avoid the patient coming back. And in this case, you remove 8 liters, then you should give 64 grams of albumin. And beyond 8 liters, the risk increases. So experts suggest that you can remove between 5 to 8 liters as long as you protect the circulating volume by giving intravenous albumin. So how do you monitor these patients? Once you do large volume paracentesis, you give albumin, you still have to keep following them closely. Important to check their electrolytes, important to check their kidney function, because these patients can develop hyponatremia, renal dysfunction, and sometimes hepatic encephalopathy. And as a patient is getting repeated large volume paracentesis, it's also important to consider sending these patients for transplant evaluation. And in some patients, depending upon their underlying liver function, they may be candidates for TIPS procedure: total transjugular intrahepatic photosystemic shunt that reduces the portal pressure. And if you can reduce the portal pressure to below the gradient between the portal vein and the IVC to below 12 millimeters of mercury, uh, that should be able to clear the ascites, but it takes time. So we talked about large volume paracentesis, the role of albumin, and also talked about role of albumin when you take out smaller amounts of fluid, especially if they have high risk features, hypotension, hyponatremia, and renal dysfunction. And we also talked about when patients are getting into trouble needing multiple large volume paracentesis to consider other options, transplant and TIPS. I want to thank authors of this beautiful review and guideline from the AASLD. I hope you take time to read this, and I want to thank you for your time. Thank you.